Just, I don't seem to be able to collapse the slides at the side despite hitting F5. So get cracking, please, Izzy, so we don't lose any more time.
Sure. Did you want to just hit the recording button again? Sorry.
Yeah, sure. I'm hitting it and it doesn't seem to be, I think we're recording a transcript rather than the actual presentation. Let me worry about that. Please just get started. I know that you want this for your study.
Thank you. Sorry about that, everyone. So I'll just begin now. So my name is Isabella Barrick and I'm a Bachelor of Nursing honours student from the University of Wollongong in New South Wales, Australia. I'm a proud Hungarian-Australian registered nurse working in intensive care. I'd firstly like to thank Ivan for the opportunity to present my research, and secondly to Dr. Rebecca Bosworth, who will be joining this meeting to support our work. So to begin, I'd like to give an acknowledgement of country, and this is an important statement of commitment to reconciliation between Australian First Nations peoples and non-Aboriginal Australians. The University of Wollongong acknowledges that country for Aboriginal peoples is an interconnected set of ancient and sophisticated relationships. The University of Wollongong campuses are spread across many interrelated Aboriginal countries that are bound by this sacred landscape and intimate relationship with that landscape since creation. From Sydney to the Southern Highlands to the South Coast, from freshwater to bitter water to salt, from city to urban to rural, the University of Wollongong acknowledges the custodianship of the Aboriginal peoples of this place and space that has kept alive the relationship between all living things. I would like to acknowledge the traditional custodians of the land I primarily work, study and research upon, the Darawal country, and pay my respects to elders past, present and future. So an overview of my presentation includes a background of our research, and I will describe our multidisciplinary approach to a proposed new model of care and detail the rationale behind the importance and urgency of our work. I'll then talk about my honours thesis, which explores oral health in custodial relationships from the lens of nurses.
Let me know when you want to bounce through the slides, okay?
Sure, thank you. If you just go to the third one there. Thank you. Oh, sorry, next one as well. Great. So in 2024, the global population of people housed in custodial settings was estimated at more than 11 million and continues to increase. In New South Wales, Australia, during the same period, 42,274 were reportedly incarcerated. First Nations Australians are overrepresented, comprising of 36% of all people in Australian custodial settings as of June 2024. So firstly, what is oral health? The World Health Organization defines oral health as the state of the mouth, teeth, and orofacial structures that enable individuals to perform essential functions such as eating, breathing, and speaking, and encompasses psychosocial dimensions such as self-confidence, well-being, and the ability to socialize and work without pain, discomfort, and embarrassment. Oral diseases are a significant public health concern, reported as the most widespread, preventable, non-communicable disease globally due to the health-related burden and socioeconomic impact. All oral diseases are chronic, progressive, and cumulative in nature, often resulting in severe and debilitating physical, social, emotional, and mental consequences. The personal ramifications of untreated oral diseases may include unremitting pain, sepsis, reduced quality of life, and decreased work productivity. Periodontal diseases is linked to cancers, cardiovascular disease, diabetes, and pregnancy complications, including low birth weight and preeclampsia. Oral health conditions share modifiable risk behaviours with other non-communicable diseases, including alcohol and tobacco consumption, illicit substance use, poor nutrition, and poor water sanitation. Thanks, Ivan. So evidence suggests oral health inequalities exist and pose significant challenges. In custodial populations, oral health inequalities are particularly pronounced. In 2018, oral health issues were the most common reasons for individuals initiating a health clinic visit in Australian prisons. People in custodial settings experience a higher prevalence of periodontal disease, dental caries, poor dietary habits, and poor oral health related quality of life compared to general populations, with tooth decay being reported to range between 57 and 67%. Environmental factors negatively impacting oral health in custodial settings globally includes overcrowding and inadequate ventilation, water quality, sanitation, hydration, and nutrition. It has been reported that the gap between the oral health of the global prison population and the general population is widening. Addressing oral health inequities for this population group provides opportunities for cost savings, with recurring expenditure on dental services in Australia was estimated to be $11.1 billion in 2021 and 2022. Many individuals in custodial settings underutilise primary and preventative healthcare in community settings. Individuals often engage with dental services for the first time during incarceration. Due to the stability of custodial environments, opportunities arise for people to reflect on, seek, and receive health treatment they require. The impact of poor oral health is not time limited and follows individuals prior, during, and post-incarceration. A large proportion of time spent in custodial settings is temporary. For example, in 2022, the median time people who were sentenced could expect to serve was 2.2 years in Australian custodial settings. Poor oral health conditions that remain unaddressed follow people into community settings and may include severe pain and missing teeth and result in reduced self-esteem with ramifications for re-entry. Globally, and particularly in countries with high incarceration rates, the health of people who journey through custodial settings and return to community settings can have significant implications for the health of communities, child health, health equity, and even global health. The high frequency of individuals cycling through custodial settings with relatively short sentences implies that an oral health promotion program could have a potentially large population-level impact. Within Australian custodial settings, nurses provide the first level of contact inside health clinics. Nurses triage and assess patients, then refer to respective services. Despite the demand for intensive oral health care and treatment, access to dental services is limited as dental professionals are often unevenly distributed, which restricts access. The increased demand for custodial dental services increases waiting times and results in the prioritisation of acute oral presentations. The current downstream dominant biomedical paradigm diverts limited resources into curative and scarce rehabilitative services. Current oral health services cannot and do not address oral health needs, thus requiring alternative models of care. Thanks, Ivan. So this is where the Oral Health in Prison study was created. The aim of this study is to build capacity with the existing workforce of non-dental custodial professionals to provide healthcare by designing an Australian-first, evidence-based, culturally appropriate and trauma-informed oral health promotion program in prison. Phase 1 included a scoping review to explore non-dental professionals performing oral health promotion in prison settings globally. Several examples of nurses providing oral health screening, education, treatment, and referrals, and some examples of correctional officers engaging in oral health promotion was identified. Thanks, Ivan. And so phase 2 is where we are currently. We are consulting with various stakeholders to explore their perceptions of a new paradigm of care, whilst also exploring their oral health knowledge, attitudes, and practices. So phase 2A is conducting focus groups and interviews with correctional officers, nurses, and Aboriginal health workers, and phase 2B is conducting focus groups with people in prison. Dr. Rebecca Bosworth and I conducted a focus group with people in prison where they provided great insights into the psychological and emotional effects of poor oral health, especially regarding seeking employment once transitioned to community settings and experiencing stigma. We will then move to phase 3 of co-designing an oral health promotion program, piloting the program, and then evaluating it. Thanks, Ivan. To ensure that this program is evidence-based, culturally appropriate, and trauma-informed, our multidisciplinary team is comprised of members, researchers, and academics from public health, nursing, medicine, dentistry, First Nations health, corrections, and consumer involvement with an expert by lived experience of incarceration. Thanks, Ivan. This includes members from Justice Health New South Wales, the University of Wollongong, Western Sydney University, and the Australian Centre for Integration of Oral Health. Thanks, Ivan. So our work and research is aligned with the World Health Organization Strategy and Action Plan on Oral Health, the New South Wales Oral Health Strategic Plan, and the Justice Health 10-Year Strategic Plan. These strategies are focused on improving oral health wellness, integrating oral health into primary care, and researching innovative ways to care for people in incarceration. These align with the Sustainable Development Goals, specifically Goal 3, Target 3.8, that is universal health coverage to ensure that nobody is left behind in achieving the targets by the year 2030. Thank you. So a member of our research team, Dr. Nicola Sutton, conducted an in-service titled Oral Health Matters. This in-service acted as a pilot work for the Oral Health in Prison study. Her initial work in 2020 demonstrated knowledge gaps of nurses working in custodial environments and limited awareness of Her work in 2020 demonstrated knowledge gaps of nurses working in custodial environments and limited awareness of dental services within Justice Health New South Wales correctional facilities. Then, in 2021, Dr. Sutton piloted her in-service and there was a 46% improvement in knowledge. This supported that oral health promotion programs are effective and provided a backdrop for our oral health in prison study. Thank you. So a combination of New South Wales correctional centres was selected for inclusion. For diverse results, the Oral Health in Prison study approached 5 adult centres, 2 male and 3 female, with a mixture of security classifications and varying dental facilities on site. All 5 centres were consulted for focus group participants, including nurses, correctional officers, Aboriginal health workers, and people in prison. Thank you. And so my arm of the overarching oral health in prison study is exploring the perception of nurses towards an oral health promotion program led by non-dental correctional professionals within New South Wales custodial settings. I was the primary researcher in an integrated review that explored the influence of oral health related knowledge, attitudes and practices on oral health risk related behaviours of people in custodial settings. This literature review will inform the content design of the oral health promotion program by identifying oral health risk-related behaviours, including alcohol and tobacco consumption, illicit substances and free sugar intake of people in prison and their knowledge, attitudes and practices towards them. The inclusion of nurses in an oral health promotion program led by non-dental professionals is supported by the Australian Registered Nurse Standards for Practice. Thank you. So all 5 correctional facilities were invited to participate in 45-minute focus groups during working hours via Microsoft Teams. A total of 13 nurses were included across 2 female settings, with both centres having dental facilities on site. Nurses were asked if they currently engage in oral health screening, education, treatment or referrals to custodial or community dentists. Thank you. So nurses expressed strong enthusiasm for the proposed new paradigm of care that included non-dental professionals delivering oral health promotion. Nurses indicated knowledge gaps in oral health and expressed low confidence in delivering oral health care. Nurses indicated utilising guidelines and policies regarding facial swelling and hemodynamic instability. They did, however, express concerns for patients not prioritising oral health as a barrier to the success of an oral health promotion program. Nurses highlighted the urgency of implementing changes, reporting daily presentations of serious oral health issues, including facial swelling, oral abscesses, and severe dental decay. Some nurses detailed that the health clinic have approximately 4 to 5 oral health presentations per day. Nurses were highly motivated to assist patients due to experiences of pain and the debilitating nature of poor oral health. Suggestions for the proposed oral health promotion program included educating nurses, correctional officers, and Aboriginal health workers to increase their knowledge and skills. Nurses suggested involving other multidisciplinary team members, including drug and alcohol and dental assistants. Thank you. So our research team created this AI-generated image to visualise what nurses assessing patients in custodial settings may look like.